Okay, I am using the chat over here, and I don't know how to say your name. I want to say Hito, but I'm not 100% sure. But I therefore I will try not to say your name unless you can phonetically spell it out for me in the chat box. But I think we're ready to go. I've got 1 minute before 4. I only had one person sign up for today, which is fine. And we will get started as long as I have confirmation that you can hear me. Can you hear me? I see that I have one viewer and I have 2 attendees, meaning me and one other. So I assume this is all of us. So it's just about 4 o'clock. So I'm just going to wait a minute since I haven't heard from you yet. Oh, okay. Mary Kay. Excellent. That's a little easier. All right, Mary, we're going to get rocking and rolling. Oh, I see. I got you. I still want to know how to say his name. Very good. Okay, so I'm going to, this software is not the best in the world, but I think I figured out how to make it work. What I've found is that there is about a 10-second delay from when I say something to when you hear it, and same when you're going to respond to me. So that can get a little bit challenging at times. Quito, thank you very much. And so what I just shared with you is ridiculous. I'm going to do it again. Obviously, I chose the wrong thing. And I should have chosen this. All right. Now you should be able to see this PowerPoint presentation. And now, just I wanted to say, Mary Kay, if you find that you get stuck, the best thing to do, you won't be able to communicate with me, is to just go out, close out, and hit that link, and it'll load you back up. It takes about 10 seconds to load back up. I found that I had some issues with my router. I had an old Vonage router, and it wasn't giving me a consistent signal. So what happens is when that happens, your screen freezes and you're unable to participate anymore or watch. So if that does happen to you, like I said, just close everything out and just go back into your email to that link and click right back on it, and you should be able to get back in. If I see that you're out for whatever reason, of course, I'll pause. Just in terms of some housekeeping, this is something that I'm doing every Monday from 4 to 5, and I really encourage you to send me more people, so makes it a little bit more worthwhile, because it's a lot of effort to put these together, but I'm sure I'll be recycling these, so in the end it'll probably pay off. At the end, we'll have a course evaluation, and in order to get credit for this, you'll have to show evidence of participation and learning, and I have after a test, a post-test, it's relatively simple. It's actually, we do it in the last few slides that you would respond to, just to show that you're participating and listening and so forth. Once you send to me the course evaluation and the worksheet that you'll be doing at the end of this presentation, I will then send back to you within a few days the certificate, and of course I keep that on file as well. The referral incentive is basically, if you have people that you refer to this webinar and they come and they list you as the person who sent them, you will get credit for that. And for every 5 people you send, you'll get to go to a free one of these webinars. And so I really would encourage that. And I'm thinking about creating maybe some bonuses or something, but this is going to take a while to build. This is only my 3rd time doing one of these Monday webinars. I'm also available to do, especially in the areas of suicide prevention, where I happen to have a lot of expertise. I'm more than happy to come to a program upon invitation and do training with a large number of social work staff if you have that situation for a reasonable fee. So my background is I went to Lemoyne College. I have a BS in psychology, and that was back in 1989. I got my MSW in 1993 and my PhD in 2010 in social work. I did get a Sampson dissertation grant for my PhD work that I was doing. I'm also a Harvard Geriatric Social Work Scholar. The bulk of my early experience was working with adolescents, but then I worked in managed care for a bit, and then New York State OASIS for over 6 years. And in that position, I was the adolescent treatment expert, and I transitioned into a research position. And I've also worked for the VA, still work for the VA for about 8.5 years now. And I've taught in SUNY in the past, and right now I'm teaching a 20-hour-a-week workload for the University of Southern California. and of course of doing this online learning series. The goals of today's webinar are to briefly review relevant statistics and risk and protective factors, refresh and update your knowledge of suicide risk assessment and related theory. I'm going to teach you a conceptualization of suicide risk that will facilitate accurate risk level determinations, and I think this is the trickiest thing in our field to kind of get this right. So I'm going to kind of give you a nice conceptualization that I've been working on actually for years now and hope to publish soon. You'll learn strategies to facilitate accurate assessment of suicide risk within systems perspective, and hopefully this training will successfully address your individual learning goal, Mary Kay. And if you want to just take a minute and put in the post in the chat box what you're hoping to get from this, to the best of my ability, I will do that for you. You can also put it on the worksheet that I sent to your husband's email. If you didn't get that worksheet, you'll still be able to answer the questions and put the answers on the worksheet later. I also sent to that email the evaluation form. But what do you hope to gain from this webinar today? If you take a minute and just put that in the chat box, it'll help me kind of shape what I'm talking about. I can spend more time rather than less on certain sections if that's going to be more helpful to you, since you're an audience of one. Okay. So as I said, there's a 10-second delay, so I'm going to assume you're working on that. And I'll throw my disclaimers up here that although I'm an employee of both the Veterans Affairs and the University of Southern California, this presentation is done independently of those positions. And the views expressed in this presentation are those of me, this author, and do not necessarily reflect the opinion, position, or policy of the VA, the U.S. government, or the University of Southern California. So I'd like to start this out by dispelling myths. What I found, having been working in this field for a long time, is that there are some myths that people still are kind of, that people don't fully understand yet. And one of them is that there are talkers and there are doers, meaning some people will talk about it, never really act, or never really take their lives, and others are the kind of people who just do it and don't give you any warning signs. There's a good body of research now that shows that people who actually go ahead and engage in the act of a suicide attempt or completion have to work through the fear of doing it. In other words, it's an unnatural thing to do, and one of the ways they do that is by talking about it, so that should always be taken very seriously. The other piece of this is there are doers, meaning some people will just go ahead and take his or her own life and not give you any warning signs, and I think there is a little bit of truth to this, to be honest with you, in that sometimes people keep their cards very close to their chest, and it's not always easy to know what's going on with them. Nevertheless, there are warning signs and ways of thinking about your clients that will help you capture people who are at great risk, even though they're the kind of people that won't give you many warning signs. Oh, good. So you're working in geriatrics, skilled nursing, assisted living, private practitioner. Most of these people have multiple medical issues and comorbidities. Most of them want to die. I want to learn about how to best address this issue. Great. This is going to be awesome for you then. He wouldn't do that. He has young children at home. Again, this is a myth. Suicide happens when people are at a time of crisis, and so they're not thinking clearly. So even though it's a protective factor to have young children at home, in that moment of crisis, oftentimes people are blinded to some of these other things that should and could be much more important and potent in terms of their thinking. Asking about suicide plants to see it, again, this is a myth. Again, we want to make sure that we do ask about suicide. Denying suicide equals no suicide risk, especially with that population, Mary Kay, that you're working with. That's a dangerous way of thinking. Facilities may tend to overreact. That's probably true. And in some ways, overreaction is better than underreaction. But then on the other hand, when do you know when it's time to react more strongly? So I'll try to touch on that today. Another myth is that if someone really wants to die, there's nothing that can be done. Again, this is a myth. There are things certainly that we can do. And I'm going to talk to you a little bit about a theory that I've been working on for a number of years now that is hopefully in the process of being published. I've got it submitted to a journal right now. He did that because he was drunk. He won't actually take his life. Again, this is a myth. 1/3 to half of all suicides are alcohol involved. So you need to take that very seriously if somebody is drinking and making suicidal attempts while they're intoxicated. Just very briefly, in terms of the latest statistics that we have, it just came out last month, about 2 months ago. Every 12.3 minutes, there's another life lost to suicide. Every 29 seconds, there's an attempt. Suicide is the 10th leading cause of death for Americans, and almost 4 times as many males than females die by suicide. In terms of homicide, the rate of homicide in this country for 2014 was just under 16,000. The suicide rate, unfortunately, continues to go up and was over 42,700 in 2014. And now there are twice as many deaths due to suicide than HIV or AIDS. I like to reflect on this study is extremely important. That this was a study, it was done in 2003, somewhat dated, but still very important. And they were looking at 76 suicide deaths occurring during inpatient care. And this is meaning inpatient psychiatric care or within a week of discharge from that care. And they found that 78% of those who died by suicide actually had denied suicidal thoughts at their last visit. So again, we have to be very careful not to rely on those statements alone and look at the bigger picture. This is a US study, and this might surprise you, Mary Kay, if you're not already familiar with these statistics, that 8.3 million Americans reported a history of suicidal thinking, which means it's relatively common. 2.2 million reported having made a plan, and 1.1 million made a suicide attempt. That's 1 in every 200, and this is a pretty comprehensive study. That's kind of a shocking statistic to me. And in the same study, those with past year substance use disorders were 4 times more likely to have made a suicide plan than those without, and nearly 7 times more likely to have attempted suicide. So there are some high-risk populations. Probably should just put seniors in here too, because it certainly is a high-risk population. But doctors, farmers, veterans, police officers, Native Americans, inmates, and those with serious medical conditions. So again, that would apply to the kinds of settings that you're in. The one thing I would say also, Mary Kay, about this particular, in terms of risk, is that the ratio of attempts to completion for the general population is 25 to 1. So for every 25 attempts, there's 1 completion. For adolescents, it goes up to 50 per 1. But for seniors, those 65 and older, it's actually 3 to 1. So that's one of the things we have to worry about, is if seniors do attempt, they're much, much more likely to actually complete suicide. So I'm just going to quickly go through this, because I'm assuming, because you're a social worker with a lot of experience, you probably know this already, but risk factors of prior attempt, but not necessarily. A lot of people who complete suicide do it the first time. Alcohol or substance abuse, we talked about history of mental illness, poor self-control, hopelessness, recent losses, and a family history of suicide, a history of abuse, serious health problems, chronic pain, access to means, which would be a big issue more for you, Mary Kay, in those settings. Sexual identity concerns has been linked to increased risk, and also recent discharge from a higher level of care. So protective factors, I'm sure you're aware of these too, so I'll just quickly go through them. Strong interpersonal connections, therapeutic alliance with the behavioral health or medical provider. Being in a caretaking role that can, goes to not only people and spouse or whatever, but also could be animals. Good problem-solving abilities, will to live, resilience, good treatment compliance, a negative attitude about suicide, strong spiritual, religious, and cultural beliefs, and good reality testing. These are all linked to, are considered buffers against suicide. And I wish I had put in here a case of an older person, but not knowing what your background was, we'll go with this for today. So we're going to come back to John, who's a 43-year-old mixed-race African-American Caucasian single man who lost his job 4 weeks ago. Since then, he's been living with what little savings he has left. Also, since he lost his job, he increased the amount of alcohol he drinks from a few beers to 3 to 4 days per week to almost daily drinking of 6 or more drinks per day. As a result, his symptoms of depression worsened, and he became both avoidant and verbally reactive towards his girlfriend, who sought to comfort him and discourage his drinking. Last week, she left him due to his behavior. So we're going to come back to this case, but I'm bringing some concepts first. In terms of theory, I think one of the most practical ways of thinking about the development of mental health disorders, and therefore the vulnerability to suicide, is this idea that people can have vulnerabilities either through adverse childhood experiences or even adult traumatic experiences, or through genetic predisposition. And these make somebody more vulnerable to mental illness and suicide potentially. And so it's usually the circumstances of the person's life that may start or trigger the symptoms of that mental illness. So minimal stressful circumstances could lower the probability of a mental health disorder, whereas the inability to cope with excessive stressful circumstances would lead to a higher level of probability of a mental health disorder. So the diathesis stress model, I think, is somewhat helpful in terms of thinking about this. In terms of specifically with suicide, Thomas Joyner is kind of the foremost theorist in the field, and he has two major logical propositions in his interpersonal psychological theory of suicide behavior. And the first is that lethal self-injury is associated with so much fear and pain and such an unnatural act that most will not carry out a suicide attempt. But he points out that people can develop the capacity to enact lethal self-injury, basically to have a habituated lack of fear of death, to learn to not be scared anymore. Like I said earlier, by talking about it, for example, is one of the ways they do this. The other part of Joiner's theory is that a desire to harm self is also necessary, and he believes and states that perceived burdensomeness and failed belongingness may drive that desire. And certainly these two, especially in the senior population, tend to be relatively true oftentimes. He would say, Joiner would say, the process of change is to build a therapeutic alliance as a potential source of belongingness and cognitive behavioral interventions to address perceived burdensomeness. So again, this would be the therapy that you're doing. And the aims would be to use the therapeutic relationship as a source of healthcare and support so that clinical approaches highlight the development of the therapeutic relationship. And they also foster a sense of belongingness and by challenging the validity of cognitions that support burdensomeness and lack of belongingness. So again, very cognitive behavioral type approach. And I find this somewhat helpful, but somewhat limited as well. This is a theory that I've been working on that I think is fascinating. And as I mentioned, I'm a geriatric social work scholar, and my work has been in the area of looking at suicide prevention for seniors. Self-preservation theory is really not really, as generally speaking, as it doesn't relate necessarily specifically to seniors, but it's more about the human evolution of our social selves. And the theory really is about looking at how we evolved socially to a point in time in our not so distant history, meaning human history. And at some point, over the last, I would say, 5,000 to 10,000 years, there's been like incredible development in the brain in terms of the neocortex or the cerebral cortex and the corpus callosum. And I believe that those major changes really kind of took us as human beings in a different direction. But I believe that underneath that, we were wired to behave in a certain way. And so the theory really goes back to this idea of what were we like before our brains kind of took over. And it's very interesting to think about that after the fact too. But one of the things that occurred to me is that as social creatures, one of the things that would be true is that we'd want to be part of a larger social group because of all the things that would offer. There'd be more protections, there'd be more choice of mates, there'd be many hands make light work, there's strength in numbers, etc. And so I would guess that in our evolution that it was very important for us to be part of the social groups we wanted to be part of. But if we were going to be, it also occurred to me that we would have to have something unique of ourselves to offer to that social group, some kind of niche, something that made us uniquely helpful to them. And that this was really a critical part probably of our adolescence and into adulthood to figure out what that niche is, and so that we could have a meaningful part of the larger social group that we want to be part of and enjoy all the benefits of that social group. And the whole theory is based in this idea. But it also goes on to think that, or to suggest that, so for example, my last name is Hunter. Perhaps I was the guy who, 10,000, however many years ago, could, go throw a spear, get the buffalo, and bring it in and feed the people. And I'm sure right now you're thinking, what does this have to do with anything? But it comes back. So what that looks like, though, is that, so I'm really good. So I do have a good arm. Maybe way back then I was a good hunter. I bring the buffalo in. I can see that people are eating and they're happy, and I get welcomed in, and I get a sense of belongingness. But it also gives me a sense of purpose. So this dynamic, I think this is the self-preservation. This is what I call the self-preservation dynamic. Is very fundamental to our core, how we operate. And like I said before, our brains have really run interference on this. What's nice about this theory is it suggests that people are innately driven to be active contributors to the well-being of their social groups of belonging, that this is part of our natural makeup. But it also suggests that when we utilize our strengths to contribute to a social group or passion of our preference and interest, a perception of having life meaning purpose results. And as you know, probably as well as anybody, for seniors, this is really critical. And so that perceived life meaning purpose is reinforced when you can see the benefits of your contribution and to receive affirmation for the same. So this is really nice to work with seniors and say, how do you find that sense of purpose, even given the situations of your difficult situation now? So self-preservation would say, as it relates to suicide, that the desire to be dead that accompanies suicidal behavior is fundamentally born out of one's lack of mutual beneficial belongingness and a missing sense of social contribution. And the implication is for treatment, Mary Kay, is that we can help individuals realign life pursuits to reestablish a sense of life meaning and purpose. And so this theory, this diagram, and I'm not going to go on too much more about this, but this diagram kind of shows a nice way of thinking about this, in that what you see in the middle is M and P, which is meaning and purpose, and it's relatively big and strong. You see the strong arrows between strengths, passions, and goal-directed actions. And the idea here is, yes, the idea here is that when your strengths and passions, your goal-directed actions are connected in such a way that you're doing something that's not only good for you, but for others, it builds that sense of purpose, and also, especially when it's in benefit of all of us. And so you see the big arrow scooping around basically says reinforced by visible benefit and positive feedback. So again, when you get to the point of seniors, it's very hard for them to feel that they can actually meaningfully contribute in the world anymore. And so the trick is, and of course I'm working with older folks who aren't necessarily in those settings, but the trick is to remind them of how important they are, what they have contributed, and the good things that they have done as part of your therapy, I would say, with those populations, especially skilled nursing facility. In the assisted nursing facility or assisted living facility, I think there's room to actually help them still contribute in some meaningful ways. So another way to think about this is some people who, some people have become completely askew here. And what you see in this diagram is contrast to this one. And I'm just realizing you're 10 seconds behind me, so that doesn't really work. Give you a second, and hopefully you'll see this diagram. What you see here, good, that's great. What you see here is, excuse me, that arrow or the triangle in the middle is very small, that the arrows are dotted, so it's a weak connection between strengths, passions, and goal-directed actions. And in this particular display or diagram, you see that the individual's goal-directed actions are just about him or her. Excuse me, just about whatever I'm doing it just for me. So you can imagine this could be an alcoholic, this could be someone who's narcissistic. But what's interesting here is that there's an arrow pointing to the psychological dissonance, and that's this thing inside, and I think this is anxiety and depression that belie something like addiction or a sense of worthlessness for someone who's narcissistic. But you also see the social dissonance, that what this individual is doing is actually harmful and creating disruption in their social relationships. So obviously, if this is an alcoholic, you can see how that gets played out. So anyway, again, the idea is to help people reconnect their strengths and passions to build meaning and purpose in their lives. So when we think about suicide, and of course I'm going to move on from that, but I can come back to that if time allows. The common feature that we think about for all depression disorders is the presence of sad, empty, or irritable mood, accompanied by somatic or cognitive changes that significantly affect the individual's capacity to function. And then all of those depression diagnoses are basically, they differ based on issues of duration, timing, or presumed etiology, really. But when we think about suicide, it really isn't necessarily just a problem with those people who are depressed. Suicide rates are also higher among people with other mental health disorders, such as schizophrenia, personality disorders, alcohol or substance use disorders, anxiety disorders, etc. So I think that's important to keep in mind. So Mary Kay, I find this to be the most useful way of thinking about suicide risk, in that you can liken a suicide crisis to a combustion or starting a fire. And you need three things to start a fire. You need fuel, and you need oxygen, and you need heat. And the fuel for an individual is the underlying social and emotional vulnerabilities, often tied to their mental illness or substance use disorders. And these are often ever present but invisible to the human eye. It's not easy to necessarily put your finger on or know exactly what's going on, especially with seniors beneath the surface, like how bad is it? But again, so if you think about fuel for a fire, the wood would have to be very dry and ready to be burned. In a sense, people who move to suicide also have to be very vulnerable in the sense of having underlying social and emotional vulnerabilities. And I'll come back to define those a little bit more. The next piece, the oxygen in the suicide crisis. Of course, for fire, you can't have fire without oxygen. But extreme emotional distress, which often is linked to subjective burdens. So this would be things like financial stress, losing a spouse, thinking of seniors now, not a burden to others now. These are things that are weighing on them that make their lives very difficult. It may be like a medical condition that is just becoming intolerable, or pain that's becoming intolerable. So the oxygen for, in this analogy, is this extreme emotional distress, but also there's a lack of adequate coping skills. All right, so you might think of that as a lack of CO2. It's all pure oxygen blowing into this situation here. If someone could have a lot of vulnerabilities and have a lot of emotional distress, but if they have great coping skills, they're probably going to be all right. So the heat, though, which is really literally the flame or the spark in this analogy, is when suicide is a real option for somebody. And I think, Mary Kay, for your situation, you can start asking questions, and I'll talk about what those questions would be, that would get at, does this person really consider suicide an option? I was speaking to someone today about a case, and the guy had gone and talked to a Catholic priest about whether or not suicide was a sin. And the clinician, I was consulting with this clinician, went on and on and on, and ultimately I said to her, well, what did the priest say? And he said, no, it's not a sin. And I said, are you kidding? Because we know that a negative attitude about suicide and strong religious beliefs are a great buffer against suicide risk. So again, making it much more in this person's mind, something that they might carry out. The other piece, of course, is means in the moment. So if somebody's they're in this emotional distress, they know, suicide's an option, they don't have good coping, they have the underlying vulnerabilities, but if they don't have means in that moment, this can be great. So when we talk about suicide prevention, this idea of creating barriers to an impulsive act, such as accessing guns, or not having medications to overdose on, or in the case of a skilled nursing facility, to ensure that they don't have easy access to something to hang themselves with, or something like that. All of those things can begin to be part of the can be part of the plan. So anyway, I find this analogy very useful, and the way to think about the heat is suicide is an option, is the flint, and means in the moment, if you think about a gun, for example, would be the steel, so flint and steel. So again, you can take a look at your patients and look at all of these different elements and begin to picture suicide risk level. So I like this analogy also. The idea here is that with icebergs, oftentimes you only see the tip, or not even see the tip, but there could be something going on. So the analogy here, of course, is if you see the tip, go deeper. So the kinds of things that you might see on the surface, and of course you probably see this a lot, is talking about death, dying, and the afterlife. Taking too much or too little medication, with ambivalence about what would happen. Heightened anxiety or agitation. Known access to weapons, financial concerns, loss of spouse, declining health and abilities, again, another one that you'll see, isolation, another one, disinterest in well-being, signs of alcohol or cannabis abuse, and difficulty with sleep. And actually, there's been quite a bit of research lately showing a strong correlation between sleep problems and increased risk for suicide. So these are some of the things, though, that you might see with your patient, and you would say, geez, I think maybe this is problematic. Let's take a closer look at this. I would suggest that you would want to look in these 5 domains as it relates back to that fireplace. The only thing that's not on this is the means in the moment. And so we'll go over each of these. So the subjective burdens, again, are those things that are weighing on them. And I see what you do. I don't know if this would apply so much for your work, but I've developed a tool called the Patient Status Update Report, which basically says to your patient, take a few minutes and go through this form that covers a number of areas like you see here, and it says, tell me what's been of increased stress, focus, or concern, and to what degree, some, much, or extreme. And I find this to be a very useful tool of getting a handle on what's going on. One of the biggest errors I see clinicians making when it comes to suicide risk assessment is this assuming that they know their patient, and assuming how they're reacting to things. So, for example, two older folks may have a completely different reaction to this idea of inability to enjoy usual hobbies. Um, and I wish I had included my statistics on this, but in a Swedish study, Rabinowitz looked at um, what the protective factors were for seniors, and he only found two. And one of them was having hobbies, and the other was being connected to an organization. And that was true for both men and women, which I think is very interesting, but those are the only protective factors. But my point is that you might say, well, they're unable to enjoy their usual hobbies or activities. One person might be like, I don't really care, I just watch TV all day. And another person may be like, why live? It might be very, very troubling to them. And you don't know unless you say them. So I noticed I know you can't do your usual hobbies. How much does that bother you? That's a really important question to ask. Loneliness and isolation, especially if somebody lost a spouse. Again, their subjective experience is something that is not necessarily easily known, and you really have to ask about it. This is also very important in terms of, and it goes beyond what Joyner says. Death ideation preparation. Have they had recent, not just current, suicidal thoughts or plans? Do they have a history of attempts? What was the nature of the prior attempts and plans? So, for example, someone who attempts to hang him or herself or try to buy a gun or those kinds of things, they're much more likely to be successful if they try again, because the method really does matter. Do they have a wish or will to be dead? Do they have a high level of exposure to death and dying, such as people, like older folks, they lose a lot of their relatives, not usually to suicide, but just by natural causes or whatever. Friends and relatives are all dying. So that's a high exposure to death and dying. Have they made preparations for suicide? Have they, done their will in such a way that they could check out at any time? Have they written a suicide note? Have they planned out their funeral, for example? Have they bought a rope for the purposes of suicide? There are a couple of them that aren't here that I think are particularly helpful with seniors. Do they think they would be better off dead? And do they think others would be better off without them? Those are two questions I think for seniors in particular you should really ask. Do they think they'd be better off dead, and do they think others would be better off without them? Preparations can be ready access to means. Again, that's where this does come in, and that piece of the split, the flint and steel, where there's ready access. And then have they rehearsed a strategy in their mind? All of those things are indications that they've moved pretty far down the road and that suicide can really become an option for them. Coping deficits, we look at impulsivity, alcohol or substance abuse, medication misuse, decision-making, problem solving. Do they make good decisions? Are they good at problem solving? Do they seek help, or are they kind of people who avoid? Do they accept responsibility, or do they kind of deny and avoid again? Are they prone to violence, other or self, but are they prone to violence? Do they have the ability to express themselves when they need to? Do they seek out help from friends or family, or do they avoid help? Are they willing to take prescribed medications for mental health issues? So this is a nice sampling of the kinds of things that you want to think about in terms of the coping deficits that an individual might have. Now, these really come in handy when you think about seniors. Lack of a sense of making contribution in the world. I really think, and again, it goes back to the theory, and I've been doing this work for years and years and years, and I have no doubt about the validity of this idea, that this idea of having contribution is strongly correlated with a sense of purpose in life. And kind of the opposite of that is to be a burden to others and to not belong. And so I really think you can look at those on a continuum. Other things that come up that can really drive someone towards suicide is just feeling unappreciated and feeling ineffectual. No matter what I do, it's one step up and 3 steps back. This is another one. This often is underlying. So again, this kind of extends Joyner's work, and I think that these other issues are very important as well. The emotional vulnerabilities that drive people towards suicide or make them more risk that dry wood is that hopelessness. And it doesn't have to be all of these. It could be any 1 or 2 of them even. Feeling trapped, like they have no other options, feeling highly anxious, or feeling a shame and guilt around a particular issue. And these are often those things, these are social and life engagement vulnerabilities and emotional vulnerabilities that are driving someone towards suicide. So again, if you see what could just be the tip, go deeper. Take a closer look in each of these areas, and I think that'll help you really get a better handle on risk level. A suggested pathway to this is to start with subjective burdens. If someone's got a lot of things going on and they're very bothered by them, they're causing a great deal of stress and concern, then I would say go ahead and look at their death ideation preparation, their coping skills. And if those aren't looking so good, you know, where are they at? Do they have a mental illness that they've been fighting with? Do they have a sense of worthlessness or hopelessness? Do they feel like they're a burden to others? So going deeper into some of those other questions is very important. I kind of like this slide because it suggests there's two things that we're doing here. One of them is dealing with the paradigm of suicide risk. And, and when we think about risk, we think about somebody has the capacity, has developed the capacity, as Joyner says. In other words, they've gone through that death ideation preparation. It's an option for them. Suicide's a real option for them. On the other hand, there has to be something driving that. Is it a burdensomeness? Is it lack of belongingness? Is it hopelessness? Is it feeling trapped or highly anxious? So those are all examples of drivers. And then again, means and motivation in the moment. In other words, they're critically upset and they have some access to means in that moment. So in my way of thinking, this is a great way to think about risk, and then think about safety planning, that you want to address each of these. On the other hand, when you want to talk about recovery and getting better and preventing suicide and helping someone, you know, just feel better, that the focus should really be on having a sense of purpose in life, especially with seniors. I like this story. I told the senior this whole thing about, you probably said the same thing, but I was working with this older veteran, and I was talking to him about my whole theory about meaning and purpose and how important it is, and I was really into it, kind of like I am talking to you. And I got to the end, and he goes, "No, duh." I just thought that was perfect. So I really do think that meaning and purpose, especially for seniors, is right in the middle of where we want to be. And according to the theory, the way you would help them build back that meaning and purpose is to help them identify their strengths that they still have, their capacities to really affect positive difference, and help them identify things that they can do, life roles in service to a cause or to others that they care about. And it could be very simple. It could be as simple as telling a grandchild a story, those kinds of things, because they're a good storyteller or they have a lot of good stories to tell. And then again, if they're doing that with someone who doesn't care or appreciate what they're saying, I think it's gonna be counterproductive. So we want them to bring their capacities and their passions and interests in such a way that others will appreciate and give them positive feedback for that. Again, that ties very much into the theory, self-preservation theory. So again, when you think about the crisis, the underlying vulnerabilities, the social connectedness and emotional vulnerabilities, that really is the dry wood of the fire, and then the oxygen is the distress in the moment and the lack of coping. And then finally, the heat is when suicide is a real option for them and there's means in the moment, the access to guns or other methods of suicide. So in terms of suicide risk assessment tips, I would say one of the best things you can do is go from remote to most recent events when you're doing a suicide history, because a couple of reasons. One is it's easier for your patient to talk usually about things that happened in the distant past rather than what's going on now. It might be a little bit more raw and upsetting for them. The other is that you can start drawing parallels in what's going on with them in terms of, for example, feeling, I'm just thinking of this one guy I worked with recently. He was saying he was feeling desperate. He had 3 different attempts. The first one, he was 15. He was feeling worthless. He was drinking at the time. And he was thinking people would be better off without him. So those are kind of the core warning signs for him, which then I brought into his safety plan. So it is definitely helpful to do a review starting from the most remote to the most recent suicide crises that this person has had. It doesn't have to be an attempt necessarily. Again, always check in on subjective experience of things. That we try not to make assumptions about how that may or may not have affected somebody. Be conservative. I would say err on the side of caution. Avoid reliance on ideation alone. That happens way too much in behavioral health, not necessarily social workers. Remember, method matters. If someone has attempted with a gun or hanging, they're more likely to be successful the next time. Remember to always address guns and consider access to guns, because Most suicides, well, actually, the latest 2014 data was, I think, 49% of the suicides were by gun. Still, though, by the far majority of completed suicides are by gun. Consider risk associated with those 5 domains that we talked about. Seek consultation when in doubt. Co-occurring mental health and alcohol or substance abuse disorders are important to pay attention to. People who have both a significant mental illness and they're actively abusing alcohol, for example, are much greater risk, as we saw in the statistic earlier on as well. And don't be afraid to go with your gut in terms of if something doesn't feel right, you think this person might be more risky, but you can't quite put your finger on it. You really should pay attention to that. In terms of, so I don't know, Mary Kay, how much you're familiar with this, but I would be remiss if I didn't touch on this idea of self-directed violence and the new nomenclature that's out there. Now, this came out about 4 or 5 years ago when SAMHSA and DOD and VA and some other national offices got together and said we have to basically come up with common terminology. And the terminology they're using now is self-directed violence. And there are several kind of qualifiers for this. So was it preparations or was it an act? And so if it was preparations, things like they wrote a note or they tried to buy a gun versus they took an overdose. With or without in any level of intent. If there's no intent, it wouldn't be considered suicidal behavior. So this is a very important piece of this. Was it preparations with or without intent? Did they have injury? With or without injury is another qualifier. And then also another qualifier is, was it interrupted by self or others? So again, you'll start seeing this nomenclature out there. And I think it's very important to just be aware of this and to start using this terminology yourself. So believe it or not, we are moving right along as we get started right on time. We're a little bit early. And the first thing we'll do is I'm going to ask you to identify 5 diagnostic criteria, or in this case, prominent symptoms exhibited by this case example. So now I'm going to go ahead and read to you a case example of, just going back to the case example actually that we were talking about earlier, this guy, John S. And bear with me for a second while I pull this up. And within this, look for what are the prominent symptoms of suicide risk based on what we've been talking about. And you want to put that on your worksheet. If you don't have your worksheet, just make notes and you can put it on the worksheet later. Okay, so I'm going to read this to you. And you know some of this already. John is a 43-year-old mixed race, African-American, Caucasian, single man who was laid off from his job 4 weeks ago. Since, he has been living with what little savings he had left. He's been unable to get a call. He's applied for several jobs, but he has been unable to get a call back despite sending his cover letter to 5 different job announcements. Since he lost his job, he increased the amount of alcohol he drinks from a few beers 3 to 4 days per week to almost daily drinking of 6 or more drinks per day. As a result, his symptoms of depression worsened and he became increasingly avoidant and verbally reactive toward his girlfriend, who was seeking only to comfort him and discourage his drinking. Last week, she left him due to his behavior. And John has a history of depression, but his feeling of hopelessness increased dramatically after she left. As a result of feeling trapped and unable to make his situation better despite how he tried, over the past week, he started considering different methods of suicide. He fears that he will suffer pain with certain methods, so he decided to look into hanging himself and fashioned a noose. While intoxicated, he tied the rope to a pipe jammed between 2 door jambs, got on a chair with the noose around his neck, and nearly slipped off the chair. His plan was to see if it would work, but when he slipped and almost carried out the plan, he scared himself. He then reached out to the crisis line for support and was referred to you, his new social worker. So, Mary Kay, take a minute to reflect on this case and what are some of the prominent indicators of John's suicide risk based on what we've talked about today. See if you can come up with 5 and put those on your worksheet. I'll give you a couple minutes to do that. Not sure what happened here. I'm not sure I'm still sharing this. There we go. Okay, so I'm going to assume that you've had an opportunity to answer that. There are a number of tools that could be very happy, and I'm glad I put this first one up there. The Geriatric Suicide Ideation Scale was put together by Martin Heisel. And this, I've met Martin Heisel. He's a psychologist who works in Canada. And he has been studying geriatric suicide risk for a long time. In fact, he conducted a study of folks 65 and older and found that perceived loss of meaning and purpose in life was a much stronger risk factor than even a health or mental health problem, which was very interesting. If you look him up, Martin Heisel, and look for meaning and purpose, you can see that. But this scale has a component of it, what do we call it? One of the constructs within it is focused on meaning and purpose. I've developed a scale called the Hunter Suicide Vulnerability Scale that actually looks at a lot of those. It looks at actually 3 areas: coping, the social connectedness vulnerabilities, and the emotional vulnerabilities. And so that is very, very helpful, I think, but it's not at the point yet where it's been published or really studied fully. There's also another scale that I developed called the Death Ideation Preparation Scale. By the way, I'm going to share both of these with you when I send you your certificates. So you're welcome to use them and make copies, making them available to anybody who comes to these trainings. And this is just an extremely efficient way to ask a lot of those questions I was talking about with regard to being better off dead, or others would be better off, and those kinds of things. The other one that I'll send to you is the one I referenced earlier, is the patient status update report. This is really the one that gets at those subjective burdens. What's been of increased stress, focus, or concern to you, and how much? So it's a very efficient way to get that information. And then finally, you probably have heard of the Columbia Risk Assessment. So I thought I should talk about that too. It's kind of, as far as risk assessments, it's one of the most popular that's out there. The truth is that none of the existing suicide risk assessments that have been studied have been really proven to be very predictive of suicide risk. But the Columbia is one of the more popular ones. I find it somewhat limiting in terms of not being as comprehensive as some of the things that I've been working on. And it's really more focused on death ideation and preparation than it is on kind of the whole bigger picture. So, okay, the next question would be then to you, Mary Kay, is describe the potential impact and benefits of using those presented assessment tools and strategies in terms of your biopsychosocial spiritual assessment process when you take a look at a client like John. So what would be some of the benefits of using one of these tools? And again, I'm going to grade this, but I mean, basically, if you have good answers, you're going to pass. We need to have a passing grade of 70 or better. I'll go back to those tools. What do you think might be some of the benefits of these? Again, put this on your worksheet. There should be a question that's available for that. Okay, and I'm just giving you a minute to do that. And we're actually right on time because technically we only have to go 50 minutes to be considered a full hour of training, and we're almost there. Okay. So we are on just about at the end here. That this is a dialogue, and what I'd like you to do is think about what you would then go to next as it relates to coping. I remember we talked about one of those 5 domains being coping deficits. And so this question is really about what would you explore with this particular individual, John, as it relates to his ability to cope. So John says, I know I need help. I don't really want to die just yet, but I just don't see a way out. The social worker responds by saying, on the one hand, you don't want to die, but you're not seeing an option besides the suicide option. Yes, basically that's right. So you as a social worker say, I'd like to ask you some more questions about how you tend to cope with stress. So the next piece here is, Mary Kay, if you would just take a minute to think about where you would go next in terms of conducting this risk assessment as it relates to questions or things you would say related to coping with stress. Okay, so we're officially at the end, but if you have any questions, Mary Kay, you can go ahead and put them in the chat box. I'd be more than happy to talk for a few more minutes about any of this stuff. If you're good to go, just let me know that. And what you would do is email your course evaluation and the worksheet back to my Dr. Joe email. And then I will send you the certificate and those 3 scales. And then also, I would ask you to consider, if you would, referring some folks to this webinar series. And if someone specifically referred you, or if you want to just give someone credit, you can go ahead and in their email say, I want to give so-and-so credit for having referred me. And I will make a note of that on a spreadsheet. And once, once that person has been given credit for 5 referrals, he or she will get a free, one of these webinars. So hopefully you enjoyed this. I'm trying to make it as convenient as possible, doing it on Monday at 4. I'm thinking some people can just stay late at work. Some people are home and can do it from home, and try to make it interesting and helpful. So I'm definitely interested in your feedback. Yeah, what I was gonna say is, so every Monday I'm doing this this webinar. It's a different one every time. I have, right now we've got 16 lined up. I want to get it to 26, so I only repeat. So my goal is to basically continue on Mondays. But I'm also willing to go to a facility. I've actually done that for NASW. I've done a few trainings for them, especially in suicide prevention, where I have a lot of expertise. I would do it on an invite basis if you had a pretty good crowd of social workers and and you're willing to pay a reasonable fee. I would come down and do, for example, a half day or a full day training and train a bunch of people at once. Otherwise, what I'm doing right now is just this Monday webinar series. But I'm open to, I may do more in the future. It kind of depends on how this takes off. Obviously, I'm hoping to have more than one person. Yes, I can email the other ones I'm doing. I'm trying to get I'm really not, like, I'm pretty good with technology, but I'm not that good with website development. So I really want to get all of them listed on my website. But yeah, we add that to the email. For next week, though, I'll be doing suicide prevention treatment. So it's going to take basically all of these theories and ideas and focus them in on how you really help somebody. The other thing that I did is I made last week I made Saturday, and I did an extra one of this. I provided this same webinar again, so if anybody missed it, they could catch up, because what I'm doing is I'm pairing it up. One's on assessment, one's on treatment. So for example, last time I did depression assessment, then I did depression treatment. This time I'm doing suicide risk assessment, then I'm gonna do suicide treatment. So if you think people who would be interested in doing this, I might do it Saturday morning at 9:45 is that time slot. I've been doing it 9:45 to 10:45. So if you think of at least 2 or 3 people who would definitely do that, I would do that so that they're caught up for the next Monday, which will be on suicide treatment. You're in Florida? Wow, that's interesting. Okay, so do you still get credit for? Oh, you're still looking to keep your New York State license then? Yeah, so the prevention treatment is next Monday. I'll do a recap at same time, 4 o'clock. I'll do a recap of this on Saturday if there's enough interest. Just basically do this webinar Saturday at 9:45. And okay, okay. I think you said yes to my question. You're keeping your New York State license, so I get that. I can also do a webinar because if you're talking about something for people in Florida, I don't know if I'm about to fly down there, but if you have a number of people who are interested in doing like even a 3-hour webinar, even if it's on suicide risk or any topic, I'd be more than happy to do a webinar for that period of time, and the fee would be reasonable. So, well, you might have to come back to New York at some point. All right, it was nice having you here, Mary Kay. I look forward to having you come again. Okay, yeah, just let me know. You have my email. Be more than happy to do that. That'd be great. Okay, take care.